Hello, everyone. Thank you for allowing me to talk to you today about pediatric COVID-19, some of the lessons that we have learned so far. My name is Preeti Jaggi. I'm at Emory University School of Medicine in Atlanta, Georgia, and Children's Healthcare of Atlanta. I have no disclosures. The first lesson that we have learned from children with COVID-19 is that children are generally less likely to get ill acutely from COVID-19. These are some data from the Centers for Disease Control and Prevention of the disease that we had in the United States between February 12th and April 2nd. It is noted that children represent about 22% of the US population, but among approximately 149,000 cases in the US, only 1% of hospitalized cases were in children. And only 0.5 to 2.0% were in the intensive care unit. There were three pediatric deaths among approximately 2,500 cases. In this bar graph, you can see throughout the age spectrum that the majority of children with COVID-19 were outpatient, and a very small percentage were in the intensive care unit. The second lesson that we have learned is that over half of children with SARS-CoV-2 infection have milder symptoms. This is some data from China, from approximately 2,000 children with SARS-CoV-2 infection, and approximately 4% were asymptomatic. 51% had mild symptoms, including acute respiratory symptoms or abdominal symptoms, but had a normal lung exam. And in the moderate category were about 39% of patients that had fever, cough, perhaps wheezing, but no obvious hypoxia. Some of these cases, in fact, had no clinical signs or symptoms, but only suggestive findings on chest CT. Severe illness was seen in 5%, in which children were hypoxic, and critical illness was seen in 0.6%, including respiratory failure, shock, and encephalopathy. One 14-year-old boy did die of infection in this Chinese cohort. However, one thing that we have learned is that there are risk factors for severe illness. In a cohort of children and young adolescents and young adults in the Washington, D.C. area, approximately 39% had underlying chronic illness. The most common of these were asthma, neurologic conditions, diabetes, cardiac conditions, and hematologic or oncologic conditions. And approximately 2% of the cohort had obesity, and we do consider this a risk factor for severe illness. On the left here, you can see a series of approximately 48 children that were hospitalized for severe illness in intensive care units across the United States. And a few things that you can note is that those hospitalized in the intensive care unit were more likely in the second decade of life, and the median age of these children was 13. Approximately 73% had respiratory symptoms, and you can again see that several of these children, 40% were medically complex, and 23% had immune suppressive treatments, so had some underlying risk factors. We do see sometimes otherwise healthy children with severe illness with SARS-CoV-2 infection, although it is not common. This is a 12-year-old that I took care of who came on day 2 of illness with fevers and vomiting. Day 3 of illness returned with persistent fevers and new dry cough. By day 5 of illness, they again came back to the emergency room with fevers and shortness of breath and were found to be highly febrile, tachycardic, tachypnic, and was eventually placed on BiPAP and then intubated and required nitric oxide, so was very severely ill. You can see the chest x-ray here on hospital day 1 and then the progression on hospital day 3. This child did not have any underlying conditions, so we occasionally do see severe illness in these children, but we haven't really figured out why some otherwise healthy children get severe illness. We have also learned that children can transmit the disease, but perhaps not very often. And I would say this is all very preliminary data, but I wanted to present a few studies that have looked at this issue. So this is a study in Europe from March 10th through April 10th of 40 children less than 16 years of age with documented illness. in whom contact tracing was performed to identify infected household contacts. In 3 of these children, there was suspected child to adult transmission, but the majority were actually suspected adult to child transmission. So that was only about 8% of the cohort. In Australia, of 9 students and 9 staff with SARS-CoV-2 infection, they noted that among 735 students and 128 staff that only 2 secondary infections were noted. So the transmission rate thus far has not been documented to be very high. This is unpublished data from our center from about 22 families in whom the child was diagnosed with SARS-CoV-2 infection. And we called them about 2 weeks later to understand who else in the family became sick. And a few things I want to point your attention to is that the first thing that we noted was most of the adults in these families had to be working face-to-face with others. And so we think that was probably a higher transmission risk. And most of the symptoms in the children occurred after actually an adult or another household contact, but there were some children who had symptoms first and then a parent developed symptoms later. But this is pretty consistent with about 8 to 10% of infections occurring, transmission being presumed to be from the child to the adult. The 5th lesson is that children may have an immune response that is actually worse than the original illness. And this is the multi-system inflammatory syndrome in children, or a pediatric multi-system inflammatory syndrome. There are a couple of different names for that. I'm going to give you an example of a child that had this condition in our center. He's 7 years old. He has no significant past medical history. He presented with fever, vomiting, and abdominal pain. And in the literature series, you'll see this is a very common theme, a lot of abdominal pain. He was irritable. He was highly febrile. And he also had a rash that started on his bilateral palms. The rash progressed on his 2nd day of illness. And by day 5 of illness, he had redness of his eyes, he had dry, cracked lips, and tenderness of his neck bilaterally. He was admitted to an outside hospital with fever, rash, and had significant tachycardia and eventually developed hypotension. He was found to be lymphopenic on his blood count and anemic, and he had high inflammatory markers with a sedimentation rate of 67 and a CRP greater than 8. He did have a clinical decompensation requiring with hypotension refractory to intravenous fluids and was started on vasopressive support. So upon arrival to our institution, he remained hypotensive, irritable with conjunctival injection, tender cervical lymphadenopathy, and a lot of abdominal pain, as well as bilateral edema of his hands and a blanching erythematous rash. His initial labs, again, noted that anemia, lymphopenia, low albumin of 1.8 grams per deciliter, and a high procalcitonin and inflammatory markers such as the C-reactive protein. So our differential diagnosis for him was, could this be Kawasaki disease shock syndrome? We know that some children have Kawasaki disease and develop shock. He is a little bit older than most of the children that we see with Kawasaki disease. Most children with Kawasaki disease are under the age of 5. We were also considering this inflammatory syndrome, which we're going to talk about in a minute. Toxic shock syndrome, it was not a diffuse erythematous rash, so that was less of a concern. And other viruses such as enterovirus, adenovirus, and some other miscellaneous infections were also considered. Eventually, he did have PCR testing that was negative for SARS-CoV-2, but he did have a qualitative IgG antibody that was positive, showing that he did have infection to antibody response to the SARS-CoV-2 virus. So this hyperinflammatory syndrome was really based on an alert that came out in the UK around April 27th, and their initial series was published in The Lancet on May 6th. And they described in a very short period of time, of 10 days, several children that had severe symptoms of requiring blood pressure support, hyperinflammation, and symptoms that could be consistent with Kawasaki disease, but not always. And what the clinical characteristics of these patients that we're seeing was that they were generally over the age of 5, which is different than most of our children with Kawasaki disease. Most had abdominal symptoms that could look like appendicitis. They were generally otherwise healthy children. Several had conjunctival injection or rash, and all required inotropic support. And that was the basis of the alert that went on in the UK. Since that time, we have seen several outbreaks that have been described. This is in the Italian cohort in northern Italy of several children with this syndrome. And after those definitions, our CDC came up with a case definition for multisystem inflammatory syndrome in children. So that's a term that we use here in the United States. And it is a child with fever, laboratory evidence of inflammation, evidence of severe illness with multisystem, meaning greater than 2 or more organ involvement. No alternative diagnosis, and positive either by PCR for the SARS-CoV-2 virus, antigen test or serology, or a known exposure within the last 4 weeks. And some of these children may fill partial criteria for Kawasaki disease. Now, you will note there are several different definitions of this illness, and this may change over time. For instance, in the Royal College of Pediatrics and Child Health in the United Kingdom, the SARS-CoV-2 PCR results may be positive or negative. At the Center for Disease Control requires either antibody or PCR positive or an epidemiologic link. And the World Health Organization also requires some evidence of documented SARS-CoV-2 infection. These are some of the clinical characteristics out of the UK of 58 children with pediatric inflammatory multisystem syndrome, so a slightly different name there. But again, you can see that of these 58 children, 26% were PCR positive and 87% were positive by IgG. So generally in our center, we have found more patients positive by antibody than by PCR. These patients have fever, they have marked inflammation, several can develop shock with myocardial dysfunction, and we can see severe myocarditis. And about 14% in this series developed coronary artery dilation or aneurysm. So compared to those with Kawasaki disease, these children are older age and they generally have greater elevation of their inflammatory markers. This was a series also published in JAMA of 17 children at Columbia in New York City between April 18th and May 5th. And these children also, you'll see the similar pattern here, lots of fever, GI symptoms, gastrointestinal symptoms, mucocutaneous findings sometimes, and then shock. And 47% were positive by PCR and 53% were positive by IgG. So some patients are positive, but for both. As far as treatments for these conditions, here are some examples of the treatments that have been provided. Of course, we have no randomized controlled trials to tell us what is the proper treatment. Many centers have been using intravenous immunoglobulin, just extrapolating from our experience with Kawasaki disease and knowing that that prevents coronary artery aneurysm in those kids. And then several patients have been treated with methylprednisolone, with some centers also using in some select cases anakinra or infliximab. Most children do well with this illness, although there have been some deaths and some ECMO use in these children. And then you can see here that some children will have had some coronary artery dilation at some point during the illness. We should remember that we should expect that some children with a phenotypically sort of a typical Kawasaki disease picture will have detection of SARS-CoV-2 from the nasopharynx. This is a 6-month-old who did not have a multisystem inflammatory picture, but really had much more of a typical picture for Kawasaki disease, who developed rash, limbal sparing conjunctival injection, dry lips, and they were treated with intravenous immunoglobulin and aspirin and did well. Their echo was eventually normal, and they had SARS-CoV-2 detected from the nasopharynx. So we know that viral detection in general is fairly common in children with Kawasaki disease, so we should expect that some children that have phenotypically sort of our normal run-of-the-mill Kawasaki disease will have detectable SARS-CoV-2 from the nasopharynx. So a few of the lessons to summarize is that children generally are less likely to become ill than adults with acute infection from SARS-CoV-2. Most children will have mild symptoms, and there are some risk factors for more severe illness, usually in the second decade of life. Obesity is a risk factor, underlying respiratory conditions or other chronic conditions are a risk factor for severe illness. Children can transmit the disease, but it may be a little bit less common than we thought, although we really need a lot more data to be able to understand that, especially with schools opening. And then the multisystem inflammatory disorder, which can go by a few different names, can occur, we think, after a SARS-CoV-2 infection. The working hypothesis is that it is probably a post-inflammatory syndrome that occurs in children. And then finally, I just wanted to leave you with this picture in that what we know about SARS-CoV-2 infection is very little, and what we need to learn is very much in the future. And hopefully we will get more information as time goes on. Thank you for your attention.